Thank you, Dr. Muhammad, for this nice introduction. It is always my pleasure to work with you and with Wael Zodi and with all the nice team you are. So I'm going to complete our workshop about azoospermia with the easy task, which is the management of hypogonadotropic hypogonadism. I have no conflict of interest. As you have here today, we have two major types of azoospermia, obstructive and non-obstructive, and hypogonadotrophic hypogonadism is one of the causes of non-obstructive azoospermia. In general, it is one of the most medically correctable causes of NOA. It's true that it is a rare endocrine disease, and it's true that it's uncommon in male infertility, affecting only 1 to 2% of infertile men, but we can cure this patient just by medication. Commonly, it's idiopathic, and it's mostly related to gene mutation. And some genetic abnormalities are well known, like Kalman syndrome, which is clinically you can detect it easily by asking the patient if he is smelling, can smell or not. All Kalman syndrome do not differentiate the type of smell. It might be Prader-Willi syndrome or several ataxia with hypogonadism. Also, it may be isolated LH or isolated FSH deficiency. It also can be acquired like hypopituitarism for different reasons like tumor, infiltrations, trauma, irradiation, ischemia, or surgery, or due to hyperprolactinemia. Sometimes, and we can see it very frequently now a day, in young people taking supraphysiological dose of exogenous androgens leading to anabolic steroid-induced hypogonadism. So, as you all know, the hypothalamus is secreting GnRH, and the pituitary is secreting FSH and LH. Both are low in this condition and resulting in low testosterone production and low production of gametes. Clinically, you can easily spot these cases having a small sized testis rather than large one. And by doing the semen analysis, either it is azoospermia or severe oligo. And by making your hormonal assay, you will find that all the three hormones, FSH and LH and testosterone, are below normal. So what is the best treatment for this patient? Both pulsatile gonadotropin and combined HCG and human gonadotropin are effective and induce spermatogenesis in this kind of patients. Actually, we don't know which treatment strategy is better because all of these treatments give good results in 75 to 80% of patients and giving similar pregnancies. However, pulsatile therapy seems to be the most physiological one because it is a rational choice for subjects with normal pituitary function. However, worldwide it is less used because it is inconvenient administration and ineffectiveness in cases of panhypopituitarism. And in Egypt is not available, so we don't use this type of treatment at all. What is done generally worldwide and in Egypt is that we start with HCG for a period of 6 to 12 months to stimulate testosterone production before adding FSH. HCG can be used at a dose of 1,000 to 3,000 2 to 3 times a week, and this dose is titrated to give a eugonadal state. In Egypt, unfortunately, you only have 5,000, but it works pretty well. One injection per week is a good substitute. If we don't reach eugonadal level, we can increase the dose every 5 days or every 4 days. What is nice with this kind of treatment that alone it may help some people in finding sperm without need to add FSH. So while giving this treatment, you have to monitor by doing semen analysis every 3 to 6 months. Bastin advised the use of FSH at a dose of 75 international units 3 times a week, but he can titrate up to 75 more units if no response happens. and he advised to continue long away his treatment until sperms appear. So prolongation of treatment is necessary to achieve satisfactory outcome. And the time of first appearance of sperm is variable. Not all patients give the same reaction, a good response take variable time. So varying from 3 to 6 months up to 36 months. In large study that has done by Burgess in 1997, 80% of patients were reporting good response. Even in patient in cryptorchidism or subtesticular volume, this patient will increase testicular volume by treatment and will give us sperm. As you can see from this graph, the more you spend time, the more patients can give you sperm, and the more count is increased with the time. This is a patient exhibiting high volume, more than 20 million sperm per ml. The more time you spend, the more sperm you have. So my advice is don't give up before 2 years of continuous therapy, as most of patients will respond and may even initiate spontaneous conception. You will be surprised, in spite of low semen quality, pregnancy may occur in high proportion of cases. This is to show you in a series of patients having Kallmann syndrome that the patient will respond rapidly with a count more than 10 million. Many of them ended in pregnancy in the first 3 months or 6 months of treatment, while those having count as low as 100,000 per ml needed a longer period to achieve pregnancies. So very surprising, patient having 100 sperm per ml can achieve pregnancy in such population. So these are really good sperm. However, full spermatogenesis in pregnancy is not achievable in all cases, despite prolonged treatment. And patient compliance can be limited due to cost, inconvenience, and discomfort associated with this type of treatment. So we need to think about patient compliance and how to help the patient to continue the treatment, not to stop it. So we may teach him self-administration subcutaneously. This is well tolerated and effective also. And we can propose an early offer of assisted conception. When we find sperm, we can freeze it and suggest the patient, if he doesn't want to continue treatment, to go for ICSI directly. ICSI is a good option, and patients like this option because many of them are elective. And some patients, in spite of treatment, they want to stop it because they don't see any results. So if we suggest micro TC or just TC in this patient, we have a retrieval rate of 70% of patients of good spermatozoa. So this is a good results of TC in such patients. Regarding the category of patients receiving anabolic steroid, it is recommended, of course, to stop any exogenous androgen for this kind of men. And the time of recovery is a real variable between these patients. And preferably, we have to give them HCG 2 to 3 times per week at a dose of 3,000 international unit. We may add clomiphene citrate because HCG may prevent, may do a negative feedback. So we need to raise FSH by clomid or by FSH therapy. And monotherapy with clomid can be an alternative also, but it's a weak alternative. Regarding hypogonadal hypogonadism, clomiphene citrate has been tried. It's inexpensive, but it requires intact pituitary function. Although one small retrospective study has investigated its role, it is a possible alternative, but we need more research about the use of clomid in such population. Once pregnancy is achieved, hypogonadal patients need a lifelong treatment therapy to overcome hypogonadism-related symptoms. So we can prescribe testosterone if no further conception is needed. But alternatively, we may think continuous gonadotropin therapy or HCG or clomifene if they still desire fertility. Of course, freezing enough sample has to be done, because if he's going to stop any of this treatment, he may lose all the sperm he has done after 1 or 2 years of treatment. So now we are happy that Dr. Silber is still with us, and we are looking to have some questions so we can answer it and discuss it. So Dr. Silber, I'm starting to discuss with you. You have heard what our talk, Dr. Wael Zohdi talk and my talk. So what is your feeling while waiting for the answer of the question submitted to our audience? Do you agree upon what we said?
Yeah, well, I think it was a great summary. Very good. A lot of the data on hypogonadotropic hypopituitarism goes back to the 90s and the pre-IVF era, even to the 80s. And what was always puzzling was why the men would come back with such low sperm counts, and yet they'd get their wife pregnant. And it was a different era then. The Ys were younger. And I think men with a very low sperm count can have a very high pregnancy rate, spontaneous pregnancy rate, if their wife is really young. And that was really one of the most surprising things. There was nothing else wrong with these patients with Kalman syndrome that were studied then. But I think the reason they came, their sperm count didn't come that high and there were some failures, is that there was an associated cryptorchidism in most Kalman syndrome patients. And so the testicle had already undergone some damage because of that associated cryptorchidism and the failure of full descent of the testes. Theoretically, every patient with hypothalamic hypogonadism, everyone should respond theoretically, but they don't. And I think the associated cryptorchidism has a lot to do with that, and why you might have a slow response when theoretically you could expect them to have sperm in 3 to 4 months, but sometimes it'll take like 2 or 3 years. And I think the testes has more problems than just the hypothalamic hypogonadotropinism.
Do you go for micro-TC in such patients if they don't respond to treatment? After how many months you may suggest this?
It's absolutely the correct thing in my opinion. If the wife is young, you can wait maybe 18 months, and even if they're still azoospermic, there can easily be still sperm in the testes, no question about it. But if the wife is 38 years old, you'll want to do your TESA pretty promptly, maybe at 6 months, because whenever there's low sperm production, you may have azoospermia, but you have a few sperm still in the testes. In fact, even cryptorchidism, which I think is maybe the biggest problem with HH, even cryptorchid patients have a pretty high percentage of success with TESA. And so depending on the age of the wife, if she's a young woman in her 20s, I'd give it a full 18 months before doing TESA, but I definitely would want to do the TESA.
Okay, thank you. Can we have the result of the poll? So regarding the first questions, which of the following is true in hypogonadotropic hypogonadism? 84% of the audience have responded the right answer. Yes, low FSH, low LH, low testosterone. If you have high FSH, is not hypogonadotropic hypogonadism, is hypergonadotropic hypogonadism. And so 84% have the right answer. The second question, what is the most important single hormone to be done? I'm happy that 58% of people suggested FSH. Yes, this is the most important hormone to be done. The second one is the testosterone. And the third one is the LH. So And the fourth one is proactin. So I'm very happy with these answers. In case of HH with fertility desire, what is the first medical treatment to start? HCG, 74% responded with the right answer. It's not FSH, it's not testosterone. Testosterone is banned in such population. The fourth question, after 2 years of hormonal treatment, the patient still azoospermic. 37% will suggest TC, and Dr. Silber agree with this strategy. 37 will give up. No, please don't give up. You have to continue treatment until sperm appear or after TC has been done. So we now, if we have some question from the audience, maybe Professor Araf and Professor Wael can submit this question to Dr. Silber and we discuss it.
Okay, I have one question. So Dr. Silber, do you go for micro-TC on the same day of ICSI, or you do it prior with cryopreservation of sperm?
Oh, I would rather do it the same. I'd rather do it the same day. Now, I know there is an issue that you might have immotile sperm that if you culture them overnight will become motile. But I think if it's not a frozen tessa, it doesn't matter if the sperm is motile or not. They're likely to be viable sperm. But if it is a frozen tessa, one idea, which is a very valid idea that you suggest, is thaw the sperm and then culture them overnight, and then you'll be able to perhaps you can pick the live ones out from the dead ones by motility. But what we do is the same day as we just incubate in pentoxyphylline. And the only reason we intubated, we just want to know which sperm are viable, which sperm are not. We don't care if it's a fresh specimen, but we know in a frozen specimen, we've probably killed half of the sperm. And so we want to know which ones are alive.
Okay, I'm going through the questions from the audience. Actually, most of the questions have been answered by the different presentations, but someone here is asking about the DNA fragmentation. So in case of high DNA fragmentation, what's your strategy in treatment of these patients?
Well, I think DNA fragmentation, if you do electron microscopy, as I mentioned in my talk, is senescent sperm. And there's going to be a percentage of senescent sperm in every man's ejaculate, fertile or not. And so the problem is when you have a high number of senescent sperm in the ejaculate, that reduces the overall potential for mean time to pregnancy. So my view would be to, if there's a bad DNA fragmentation, I'm sorry, I'd be aggressive and I would go to ICSI. And this is where IMSI could be valuable, but also you can do your ICSI by putting the microscope at 400 instead of the usual 200 or 100. And IMSI really isn't very easy to do unless you go down to a magnification of 800. And so 400 magnification is not bad. And I would just try to pick out the sperm that had the most perfect looking sperm heads. Not as good as electron microscopy or EM or IMSI at 5,000, but I think you can pick out the viable sperm. But there is a second approach. I mean, that's what I'm talking about to make it easy on the man. But I think most of the sperm DNA fragmentation is caused by senescence. And so I think for those cases with high sperm fragmentation, you just do TESA because you know you're going to have fresher sperm.
This was actually my next question because in our center we're adopting TESA in these cases. So I was just going to ask you what you answered.
I think it's the right way.
Yeah. Another question is, in cases with 100% abnormal morphology, do you go for TESA or you just go for ejaculate sperm in ICSI in these cases with 100% abnormality?
I don't know if it's 100%. I'm always skeptical about that. And it depends on what the morphologic abnormality is. If it's all round-headed sperm, well, you do ICSI with the ejaculate and calcium ionophore egg activation because you don't have an acrosome. And I think it just depends on what the defect is. if it's a poor acrosome, but there's some acrosome there causing the morphology of the head to be abnormal, again, I would do ICSI and activate with calcium ionophore. We do that for 10 minutes, half an hour after the ICSI injection. But if it's like they call it, if they call it 100% abnormal morphology, but there's a few morphologically normal sperm, you can still get away with doing ICSI. But if it's truly 100%, I think it's important to do calcium ionophore activation after the injection.
Totally agree with you, sir. So there is another question asking about, is there a threshold for FSH level above which a sperm retrieval is not advised? So how much high FSH, when you see it, you say, okay, I will not go for TACI in this patient?
Well, we don't care how high the FSH is. The FSH, I'm sure, is helping us, actually. No, we studied it a long time ago. FSH is not a good determinant of whether you have a few sperm, because normally a test is making 100 million sperm a day, and we're just looking for 5 or 10 sperm, so the FSH is just not going to be indicative.
Totally agree. Actually, in some of the cases, the higher the FSH, the better the
I
basic.
agree with you totally. I agree with you totally on that.
So, Dr. Wael, you have the microphone now if you need to ask more questions.
Yes, just one question regarding the sperm processing after TC. Do you use the enzymatic digestion? And what's your experience about enzymatic digestion for after mechanical treatment of testicular tissue?
I'm not sure I understand that well. My hearing isn't so good.
The use of enzymatic digestion, enzymatic treatment of testicular tissue.
Enzymatic. Oh,
Yeah.
Enzymatic versus physical. Okay, we wrote some papers on using collagenase, and those papers were in the 90s because we were very excited about maybe collagenase being more efficient. But now we think if we just do I showed you that one slide, a really good physical preparation, I think that's absolutely as good as collagenase, and I don't worry about potential toxic effects of the collagenase. But I'll tell you, if you're gonna culture spermatogenic stem cells, that mechanical dissociation is worthless, because the stem cells are located right in the basement membrane, and then you would have to use collagenase to liberate those spermatogenic stem cells.
Yeah, I agree. Because we compared collagenase versus mechanical treatment, and there was no difference. But we are hoping that if we add the enzymatic digestion after erythrocytizing buffer or after mechanical, it may add some up. Maybe, I don't know.
No, I agree with that. One thing's for sure, if you want to get spermatogenic stem cells that are more and more important, you have to add the enzymatic treatment. You just have to.
Yeah, very good. Okay, thank you so much.
So, Dr. Silber, I have one last question. It's actually a hope. We are all waiting, us and our patients with failed surgical sperm retrieval, for the advances in the stem cell therapy and the production of new sperm. So we are hoping that soon you will share with us the nice information and the hope for these patients that we can synthesize the sperm from the somatic cells, and we are waiting for it. Thank you so much.
Well, thank you. I look forward to that. That can be the next talk when we meet again.
Yeah.
And whenever COVID's over, I'll bring all the
Dr. Silber, there is a question.
set it all up for you.
I have a question from Dr. Ashraf Abu Ali. He's asking about your strategy. Do you prefer doing testicular sperm and freeze it, or you prefer to do it the same day as the ovum pickup?
Well, I prefer to do it the same day as the ovum pickup. But there is a really good argument for doing it the day before and culturing the cells overnight so you can see motility. But my experience is that that you don't care about the motility in the testicular sperm because the motility is just related to an aging process. And you only care about it in terms of giving you an indication of viability. So I do it the same day. Why? Well, it's very convenient for the patient. The wife comes in for her egg retrieval, and the same day the husband has his sperm retrieval, and it's emotional, it's familiar, it's spiritual maybe to do it the same day, but that's just the way I do it. But I wouldn't be against doing the test of the day before.